Welcome to LPN LaunchPad's assessment of the eyes, with a focus on the pupillary response and extraocular movements assessment. We will explore the essential techniques, underlying anatomy, clinical implications, and assessment procedures integral to neurological evaluation. Accurate assessment of pupillary responses and extraocular movements is vital in neurological examinations. These assessments enable clinicians to evaluate cranial nerve function and infer brain integrity. Notably, variations in pupil size, reactivity, and eye movement patterns may serve as early indicators of neurological impairment, increased intracranial pressure, or systemic pathologies. Timely detection of changes in these responses is crucial, particularly in emergency scenarios, such as trauma, stroke, or brainstem dysfunction. Early intervention, based on these assessments, can be life-saving. Understanding the anatomy behind the pupillary response is fundamental. This process is regulated primarily by two cranial nerves. Cranial nerve. 2. Optic nerve, which transmits visual stimuli to the brain, and cranial nerve 3, oculomotor nerve, which controls the pupil's constriction through activation of the pupillary constrictor muscles. In the pupillary light reflex, light stimulation occurs when light enters the eye. The retina detects it, and the signal is transmitted via the optic nerve, CN2, to the midbrain. The response mechanism is the oculomotor nerve, CN3, which then triggers the pupillary constrictor muscles. Direct response. The pupil in the stimulated eye constricts. Consensual response. The pupil in the opposite eye also constricts, demonstrating neural connectivity between both sides. When conducting a pupillary response assessment, begin by visually inspecting the pupils. Next, use a pen light to evaluate the light reflex. Carefully observe and compare the responses in both eyes to identify any abnormalities. During the nurse's inspection, focus on three key characteristics. Are the pupils equal in size? Shape? Are the pupils round or irregular? Symmetry. Do both eyes exhibit similar appearances? Utilize a pen light to assess the light reflex by examining both the direct response, reaction in the eye exposed to light, and the consensual response, reaction in the opposite eye. Additionally, observe the speed of the response, noting whether it is brisk, sluggish, or absent, and compare the findings between both eyes. Closely observe the pupil's reaction speed. Document whether the response is brisk, sluggish, or absent, and compare the responses bilaterally to ensure no discrepancies exist. Standard indicators in clinical practice include P, E, R, R, L, pupils equal, round, and reactive to light, which confirms that the optic, CN2, and oculomotor, CN3, nerves are functioning properly, and PERLA, pupils equal, round, reactive to light and accommodation, which extends the evaluation to include the pupil's ability to accommodate near vision. Be aware of several abnormal pupillary presentations. Anisocoria, unequal pupil sizes, which may suggest increased intracranial pressure or cranial nerve dysfunction. Fixed and dilated pupils. These findings can indicate severe brain injury, herniation, or uncal pressure. Pinpoint pupils, often associated with opioid toxicity or pontine hemorrhage. Horner's syndrome is characterized by meiosis, constricted pupil, ptosis, drooping eyelid, and anhidrosis, lack of sweating, reflecting sympathetic nervous system disruption. Assessment of extraocular movements evaluates the integrity of cranial nerves responsible for eye movement. CN3, oculomotor, CN4, trochlear, CN6, abducens. This evaluation helps detect abnormalities in ocular coordination and muscle control, and may indicate conditions such as increased intracranial pressure, cranial nerve palsy, or brainstem pathology. Instruct the patient to follow a pen light or the nurse's finger through the 6 cardinal directions during an extraocular movement assessment. Observe both eyes for smooth, coordinated movement, and document any abnormalities, such as nystagmus, strabismus, or movement restrictions. Abnormal extraocular findings may include nystagmus, involuntary, repetitive eye movements that may suggest vestibular dysfunction, cerebellar disorders, or intoxication. Strabismus is a misalignment of the eyes, often indicative of cranial nerve palsy or muscular dysfunction. Ptosis is drooping of one or both eyelids, frequently associated with oculomotor nerve dysfunction or conditions like myasthenia gravis. Ophthalmoplegia is paralysis of eye movements, which can be a sign of brainstem stroke or a myasthenic crisis. Several conditions commonly affect pupillary responses and extraocular movements. The third nerve palsy impacts CN3, leading to ptosis, pupil dilation, and impaired ocular movement. Internuclear ophthalmoplegia, INO, characterized by the failure of one eye to adduct, frequently observed in multiple sclerosis. Parinaud's syndrome, associated with limited upward gaze, typically due to lesions in the dorsal midbrain. Recognizing abnormal findings in pupillary and extraocular assessments is crucial for early intervention. Clinicians should compare baseline and subsequent assessments to monitor neurological changes. Accurate documentation should include pupil size, shape, reactivity, and any noted abnormalities, e.g., strabismus or nystagmus. Prompt communication of these findings to the healthcare team is essential. In summary, assessing pupillary responses and extraocular movements is a cornerstone of neurological evaluation. Abnormal findings may signal severe conditions such as brainstem dysfunction, increased intracranial pressure, or cranial nerve damage. Consistent, accurate assessments and documentation are vital for effective patient management, and prompt recognition of abnormalities can prevent severe complications. Here are some NCLEX study tips to help improve understanding of these assessments. These tips will focus on understanding cranial nerve functions, accurately assessing pupillary responses, and recognizing common neurological disorders. Begin by mastering the functions of the cranial nerves. CN2, optic, and CN3, oculomotor, are essential for the pupillary light reflex. CN3, 4, and 6 govern extraocular movements. Familiarity with the clinical presentations of dysfunction in these nerves is imperative. Ensure consistent assessment of the pupillary response using the Perla criteria: pupils equal, round, reactive to light, and accommodation. Evaluate the direct and consensual light responses, and be vigilant for abnormal findings, such as anisocoria, pinpoint pupils, or fixed pupils. Develop a comprehensive understanding of common neurological disorders. Recognize the key signs of brainstem herniation, including fixed pupils and abnormal extraocular movements. Understand how conditions such as myasthenia gravis affect ocular muscles and, consequently, eye movement. Now consider an NCLEX practice question. Scenario: a nurse is assessing a client with a head injury. The client's pupils are unequal, with one pupil fixed and dilated. What is the priority nursing intervention? Options: A. Reassess in 30 minutes. B. Elevate the head of the bed to 90 degrees Celsius. Notify the provider immediately. D. Administer pain medication. The correct answer is C. Notify the provider immediately. A fixed dilated pupil is a critical finding that may indicate brain herniation or increased intracranial pressure. Immediate intervention is necessary to prevent further neurological deterioration. Note that elevating the head of the bed to 90 degrees could compromise cerebral perfusion in this context. Consider this next practice question. Scenario: a client with a suspected stroke is being assessed. Which cranial nerve is primarily responsible for the direct and consensual pupillary response? Options: A. Cranial nerve 1, olfactory. B. Cranial nerve 2, optic. C. Cranial nerve 5, trigeminal. D. Cranial nerve 8, vestibulocochlear. The correct answer is B. Cranial nerve 2, optic. CN2 is responsible for sensing light and transmitting this information to the brain. The oculomotor nerve, CN3, subsequently mediates the constriction of the pupils. The other cranial nerves listed do not contribute to the pupillary light reflex. Here is another practice question. Scenario. During an extraocular movement assessment, a nurse observes that the client's right eye fails to move laterally when following an object. Which cranial nerve is most likely affected? Options. A. Cranial nerve 3, oculomotor. B. Cranial nerve 4, trochlear. C. Cranial nerve 6, abducens. D. Cranial nerve 7, facial. The correct answer is C. Cranial nerve 6, abducens. The abducens nerve controls the lateral rectus muscle, which moves the eye laterally. Dysfunction in cranial nerve 6 results in an inability to abduct the affected eye, whereas cranial nerve 3 controls other aspects of eye movement.
Hey there, this is Brian. I am the creator of LPN LaunchPad. I want to say thank you for learning with us. In addition to these videos, I've created a series of free adaptive quizzes in ChatGPT. The link to this video's quiz will be listed in the description below. Help me keep this project alive by hitting the like and subscribe buttons.